Hi, I'm Dr. Randy Martin, and I want to welcome you to the Marcus Heart Valve Center. We're thrilled to be joined by Dr. Tirone David, who's known to many of you, and three of my outstanding colleagues, Dr. Morris Brown, Dr. Fred Milla, and Dr. Peter Barrett. So this is really meant to be a conversation these guys have with the master. We'll call you the master.
The experience, the older guy.
The gray-haired master, the silver-haired master. So we're thrilled that you could join us, Tyrone. I mean,
Thank
really
you.
are.
It's a pleasure to be here.
It's Fred. Take it away.
Well, I think you'll probably learn a little bit more of what we're trying to build here in the Marcus Heart Valve Center, and I think you having a valve program for many years, I think it would be worth it for us to understand a bit. How do we set things up? What are key parts in forming a heart valve center? And what are your, kind of suggestions as to how to proceed in such an infancy?
Interesting you are saying that, because Randy and I were talking about this when I finished my training in '78. And my mentor told me, you're going to have to leave, go elsewhere, learn a trick, become an expert in one area that we don't have here, and bring it back to the environment. Very naive. I was 31-year-old when I finished my training. I said, sure, why not? Live in Europe for a year, it'll be fun. But it occurred to me, so I learned, and then where the patient gonna come from?
Right.
But the say, building they'll come, is likely true. But to build, you need a champion.
Right.
When Dave Adams came to New York, and I'm giving Dave because you trained with Dave, I did not believe he was going to succeed, honestly. I said, New York is a very competitive market.
Yeah.
Those guys don't speak to each other. It's a cutthroat environment, more units than the city needs.
Mm-hmm.
And yet, he's there for 12 years now? How many years now?
Yeah, since 2002.
Dave has a practice exclusively of mitral valve repair, mitral valve surgery. He may do something else, but he's well known as the mitral valve. So he had the expertise, was a champion of the cause, and the patients came, and came by the hundreds. I think it's necessary not only to have a supporting structure, a building, cardiologist, patients, but you have to have a player who's going to really show to the environment they can do what's expected of the person.
So super specialization, and then
I
really
believe
in building numbers. Is that right? Building experience and numbers.
Absolutely, yeah.
Now, to be a successful valve program, you have to have all the facets. In other words, do we need a mitral valve surgeon? We need an aortic root surgeon.
We do.
Should we be able to do valve sparing root replacements, Ross procedures, in order to really say we're a comprehensive group? You think, how important?
I think it is. You have to give the whole spectrum, not only clinically but academically too, to get academic credibility.
Right.
You're not a guy or a center that does one operation very well done, and if the patient has any deviation from the standard,
Right, you can't.
it falls apart.
Yeah.
So you have to have the expertise in the group to take care of any type of problem. I think that's what the heart valve disease program is.
Right.
And have our counterpart in cardiology for the percutaneous technology now. Whether we like or not, is here to stay. So don't fight, join them, and become part of your program.
Or as Tyrone said, he did 3 aortic valve sparing operations yesterday.
Yes.
I mean, I know you're doing, Morris does does a lot of
I
aortic.
do, yeah, fair number
thoracic.
of roots. Let me ask you a question about bicuspid valves, because a lot of these people, they come in, they're pretty
bicuspid
young.
valve, yes.
They got a bicuspid valve, they got a 4.8, 5 centimeter AC in the aorta. How do you decide when to leave a bicuspid valve and spare it and when to replace it?
Bicuspid aortic valve, if the patient is older, we replace it.
Right.
We don't care very much, particularly if they're over 65, 70.
Right.
I think there are bioprostheses available there. In the elderly patients, a sure thing. You know that we have large experience with 2 commercially available, Hancock 2, it's an old valve, and Magna or Piedmont. Mm-hmm. And they're So you implant on a patient over 65, usually you don't see the patient again. That the valve outlasts the patient, particularly if they have comorbidities. The ascending aorta, we are very aggressive in replacing it. Anything more than 40 millimeters, we think should come out.
Interesting.
If you're there for the valve, younger patients are a problem. Because usually the younger patient come to you either because of a normally functioning bicuspid aortic valve and an ascending aortic aneurysm,
Right.
or a dysfunctional bicuspid aortic valve, by and large, is aortic insufficiency.
Yeah.
And the aorta is 40 millimeter. So it depends why you're there. I think the mixed lesions, we do not have a good operation yet. I tried in the 80s to use bovine pericardial patches. It's less durable than a prosthetic valve. So you keep wondering, is it worthwhile to take a chance? But there's a 10% failure that you don't expect to fail and fail. And they come back within 5 years. You'll say, gosh, 25-year-old, I'm reoperating by the time he's 30. It's not reasonable. So I shied away from this. The incompetent with pliable tissue is different. We learned recently that, I say at least 7-8 years now, that bicuspid aortic valve that becomes incompetent, by and large, becomes incompetent because the annulus dilates.
Right.
The disease is in the annulus. I've been saying this for 2 or 3 decades, looking at results of the Ross procedure. The Ross does not work very well in patient large annulus. It doesn't work well because the disease likely is in the fibrous skeleton of the heart, not in the leaflets that we operate on. So in those patients doing a remodeling procedure, not the remodeling, I'm sorry, the reimplantation procedure, putting the whole valve in a tube. We have been doing this for 15 years now, and so far, they are lasting.
And how do you size that?
The height of the normal cusp, leave the conjoint alone. Take a look at, I do by the height. One of my former trainees, Gebrino Okuri, he measured the height of the commissure. In other words, pull both commissure up in the air, measure the distance between the nadir and the top commissure, and that's the size of the graft. Works for him. It's the same thing if you take a look at the height of the cusp and extrapolate. If a cusp, say, is 18 millimeter,
Right.
how big the hole it can close? Well, it depends in the conjoint cusp. By the time you repair the raphe, if it's 14, 15 millimeter, you have 14, 15 plus 18. The hole should not be more than 24, 23. More importantly, if you take a look at normal human being, the aortic canal is very small. My body surface area is 2. I did an echo last year and I measured my annulus. It's 22 millimeter. I'm not the hypoplastic annulus. That's a normal aortic annulus.
Right. It's just normal
So if I need an
size.
aortic valve replacement one day, the surgeon's going to struggle because it's small annulus,
Small annulus.
for my size. But that's how human beings are. We normally have small annulus. Bicuspid aortic valve is abnormally enlarged.
Peter?
In a follow-up to that, then, when do you choose to do a root enlargement, or like a Manugian? Morris had a young Ethiopian lady yesterday who had a previous valve, and he had to do an enlargement to get a 23 in. When?
Oh, we are very aggressive. If you look at our longitudinal outcomes in valve replacement, 1 patient in 5 had a patch enlargement. I believe that mismatch is a real thing and affects survival. It doesn't affect survival of the 80-year-old,
Right.
because the 80-year-old, they have so many comorbidities, they die before the mismatch killed them.
Right.
But a 40-year-old, you shorten their lifespan
Sure.
if you leave them with stenotic valve. We present a paper at the European Cardiothoracic last year in Vienna. One of the fellows presented a combined experience from Ottawa and Toronto in patients under 60. Mismatch and age were the 2 most important determinant of outcomes late. Remember, people under 60 usually don't have coronary disease. Very few have renal failure. Very few have bad lungs. Gonna die of what? Cancer
Right.
or heart, because you will replace their valve. In those patients, mismatch emerges as a predictor of mortality. Patients with small valves do not live as long as those with bigger valve. And believe it or not, the cutoff was precisely what the guys from Quebec, Jean Demenil, he said 0.85 centimeter square per meter square of orifice. So that number, I think he came up with the number looking back, who did well, who did not do well functionally, but affects survival. So you need a valve that gives the patient 0.8 centimeter square per meter square, not to adversely affect survival.
Tyrone, I wanted to go back just for a second, Peter, if I could, about the aorta, because I see so many, I get sent echoes from people all over the place who have got a congealing malformed valve, could be a trileaflet who has AI, and they've got aortic roots, aortics that are 4.4, 4.2, 4.1. You know, I think the new American guidelines are going to be pretty conservative because of the Mayo data that says these things don't dissect and all that stuff. I mean,
Mayo and Hospital for Sick Kids, I mean, they had 800 kids there. We don't see dissection ruptures.
so they don't dissect. But you said that
Well, they do, but very, very rarely. Certainly, much more rarely than the risk of the operation.
do we put them
So the
on?
moment the operation is more dangerous than the risk of dissection. I mean,
So that's not an indication
I
to
don't
operate.
think so. I think 5 centimeter ascending aorta, bicuspid aortic valve, normally functioning, is too aggressive to replace.
Below 5, or even at 5.
Guidelines now call for 5. At 5, you operate on the
Right.
patient. I think it's too aggressive. And that's the paper I'm preparing.
I got it.
We
I
have
got it.
20 years follow-up in our patients now. This is why I ask you if John data is, if he has a bunch of 80-year-old there as well, of course they're going to die. Because they didn't die necessarily from rupture, they died from other causes too.
Yeah, no, they,
No, they died at that 6 centimeter, you know,
No,
on a
6
cold
centimeter.
winter morning, they were dying.
6
That's
centimeter
when they were
kills.
dying.
6 centimeter does rupture.
Okay, so you're saying 5,
I
okay.
think between 5 and 6 is the indication for surgery. The old guidelines of 55 likely match better what we can do surgically.
Okay.
In other words, we harm patients, but they don't harm 5.5% or 6%, the way the annual rate is
Okay.
of death for those patients.
So bicuspid aortic valve, aortic stenosis, that's what the indication for surgery is. What's your cutoff then on the ascending replacement? So
It
does it
depends
depend
on
on
two things:
age?
patient's age and what the valve you put in the patient. A 40-year-old want a valve prosthesis, the aorta is 40 millimeter, or leave him alone.
Right.
He's going to come back anyhow. A 70-year-old wants a valve prosthesis, like I can leave him alone.
Right.
Let's reverse now. 40-year-old, 40 millimeter aorta, he wants a mechanical valve. If the patient wants a mechanical valve, he's telling me, I don't want to be reoperated on. Isn't that,
Don't ever want to come back.
so they don't want to come back, period. Not to come back for your aneurysm. They don't want to come back anymore to see you. You're a nice guy, but I'm doing an operation once only.
Right.
We're more aggressive. We replace everything with the Dacron, even at 40.
Would you do a root replacement in that instance?
I think a root replacement
because
because
it's bicuspid valve, so the sinuses
if
are.
the root is entirely normal, you do supracoronary.
Right.
But more often than not, if you take a look at the posterior sinus,
It's going to be dilated.
it's dilated.
Yeah.
So you're going to have at least a posterior sinus aneurysm in the future. Replace the posterior sinus.
What about a lot of the patients come in and we're trying to spare the valves, but where the commissures join the aortic wall, they're fenestrated. You know, they're attached by a series of cords. That's a marker for early failure. How do you decide when to leave it and when to try to fix it?
It depends on the patient's age again.
Yeah. Say it's a young patient, 45.
45 is not young anymore, but that's all right.
That's young. We
I
could-
Pretty
know.
young to me.
No. I operated yesterday. Operated on a 17-year-old Luigi syndrome, a 22-year-old boy in our fans, and a guy with familial aneurysm at 36. These are young.
Yeah.
This you don't want to be putting mechanical valve in 17-year-old girls. So you have to do whatever it takes to save. And if you saw what I did to the aortic valve, you're going to say you're out of your mind. It's not going to work because every single cusp requires a Gore-Tex reinforcement at the free margin. But we have been doing this since 1994, and they haven't come back yet. They're not leaking. So we reinforce the free margin.
Just
This patient
reinforce.
mentioned with the commissure is suspend the large fenestration. It's going to break any time.
Right.
You take one Gore-Tex, you weave along the free margin. Bring the Gore-Tex below the fenestration. So the fenestration has two Gore-Tex.
Right.
One goes flat in the bottom of the fenestration. The other one is the
Up
new.
to the top and tie it outside.
Absolutely, outside the graft.
Yeah.
We need to have a telestrator here for him.
Yeah, I
No,
understand.
no, I think it's,
That operation works.
Okay.
And saves a lot of the aortic valve, like Gore-Tex saves a lot of mitral valve that normally we cannot use Carpentier techniques of chordal shortening, chordal transfer. There's nothing to short or transfer sometimes.
Fred, you saw his paper in Circulation last year that where you look back on your mitral valve
On the
repair
mitral
rate,
experience,
you had over
yeah.
800 sort of things. I mean, it's pretty
Was
impressive.
it
for
was
one.
it shocking to see the recurrence rate in anterior leaflet isolated? Because it was the
It wasn't
highest odds
shocking
ratio.
because we knew this all along, but and we changed in the 90s. We once we discovered that the anterior leaflet failed more than posterior leaflet, I used to say it's the Gore-Tex. You're putting only two Gore-Tex.
More.
I use an average of 26 Gore-Tex per patient, that paper. 26 cord is a lot of corda.
Wow.
So the anterior leaflet had like 10, 12 new corda, and it still failed. But if you take a look who failed, there are different patients. They're very large anterior leaflet. A third of them had bicuspid aortic valve. And we published a paper on this. Patients with bicuspid aortic valve will develop mitral insufficiency. The anterior leaflet is huge. The posterior, almost non-existent, tiny. Is it an anatomic abnormality that predisposed to failure no matter what you do? Because if it's bigger, it means the tension on the free margin is
gonna be much higher.
much higher, it's wall tension. So I don't know precise why, but in any longitudinal outcome, it looks like at 20 years anterior leaflet is a bad guy. It doesn't mean you should repair them, because 60% is still perfect at 20 years.
Yeah.
But fail much more than posterior.
Wow, that's a lot of cords because I think Adams
But
typically puts
Two or three or four.
two or
Yeah, but
three,
Dave uses
four
it-
at most.
Dave uses the original technique. He brings two quarters from the muscle. We do differently. We start in the muscle, come to the free margin, loop twice, go back in the muscle, come back, you loop twice.
Okay.
So the same Gore-Tex create 10, 12 corda is
Nice.
much faster.
Yeah.
Particularly if you do through a small incision or a big tie knot in the hole. It takes too long to tie those knots.
Yeah. And all of them had rings, so it wasn't
No,
something that you
ring-
weren't using a ring at first and then you started using
No, the
a
ring was a much earlier experience. It was in the early 80s. Those that had acute mitral regurgitation, or what they call the fibrillation deficiency, they are tiny valves. They're small leaflets. You say, gosh, if I put a ring here, it's going to become stenotic. Like, 24 rings, 26 rings. Say,
Yeah.
It's too small for a big person. So we didn't. And there was no MR in the operating room. It was a mistake. They came back.
Yeah. So what do you do now? You just put a small
ring.
ring, put a small ring,
No, for a posterior band only.
a band.
I think in myxoma disease, I really don't believe they need a rigid ring. Patient had normal ventricular function.
Right.
And the function is impaired, I think you
That's
have to put a
different.
rigid ring. There is enough evidence to support a rigid structure for ventricular dysfunction.
And it's more a rigid ring you're using?
I use more rigid.
Right.
Well, rigid Carpentier Physio 2 I'm using the past year, before the original Carpentier.
Right.
I trained with Alain. I learned I was comfortable. I'm sure there's a dozen ring out there
Right.
that works very well. So you can-
3 dozen.
Yeah.
No,
Everybody's got one but
37.
me.
There are 37 rings out there available. So
Yeah.
either all wrong or all good. So
Just use what you're comfortable with.
Absolutely.
The
I think
physio,
use it.
physio 1, physio 2.
I think the normal ventricular function, I use a band only. Medtronic has a band, which
Right.
the hospital likes, the cheapest one,
Right.
and one for all sizes. You cut what you need. And for rigid, we use Carpentier Physio 2. At the present, up to 2 or 3 years ago, the classic Carpentier. I think it's a very good. It's old. It's 40-year-old, but works.
Right.
Don't have to do something modern to work well. So. And then remember, whatever we invented today in medicine, we have to wait for God knows how long to say if it's right or wrong.
Yeah.
It has to pass the test of time. Unlike cameras and television and computers.
iPhones.
They can discover right away if it works or not. We have to wait. Biology is a miserably difficult thing.
Speaking of that, and only because there's no real track record, where do you view the mitral clip?
Well, there is record. There are enough data to. I think some of the diseases is very tough to compete against surgery. Circulation has a paper showing that 94% of the patients don't come back at 20 years. And the clip give the patient 3 or 4 years and destroy a valve. I think the company picked the wrong patient to randomize against. On the other hand, the bad ones, the ones you don't want to touch because they're
Right. Calcified annulus or very
calcified
sick.
annulus
They're
or
sick.
the ventricle very bad or multiple associated disease that we harm them,
Right.
stroke them. If they can put a clip and reduce the mitral regurgitation
Right.
and change the function class 4 to 2 or 3 even, get them out of the hospital, why not? I think there's a place for that device. I think in isolation for a floppy valve is not a good therapy.
Are we going to be going that way for devices in secondary or functional MR? You think more and more?
Or it depends how your Obamacare is going to go. If your Obamacare becomes more like an Asian healthcare system, you guys are going to be facing an interesting new.
We're going to use chewing gum. Is that right? You're going to take some chewing gum.
No, I don't think it's bad, to be quite honest. If Mr. Obama has my opinion, say don't introduce Obamacare you're introducing, put them in a public vote and a referendum, increase income tax by whatever, 4 or 5%. In Canada, it's called the sales tax. What do you call the?
Consumption?
No, this is
So you-
goods and service tax. Now it's a harmonized. Before it's like the English good and service tax. Everything you buy, there's a percentage, and that money goes to healthcare. Part of it goes to healthcare. And I'll bet you if they introduce a goods and service tax in the United States at 5%, you can buy all the insurance companies and make it public. And then they can start dictating if put a clip in an 80-year-old or not. Until then, it's a free market. And
I don't want to get out of the political spectrum, and we won't talk about. I could ask you about tickets to the World Cup in Brazil if you've got any contacts. But let me ask you about because I'm sure we deal with this a lot, and we hear people the concept of minimally invasive surgery, robotic surgery. I mean, you made reference to this. Is that the wave of the future, or do you want to have the right operation done
no, the
and
right
not worry
operation
about
done.
the approach?
The right operation done first, but unfortunately, whether you like or not, the only thing the patient takes home afterwards is the scar. And they look in the mirror 10 years later, and that scar, no matter where the scar is, it reminds him what he had done to his wrist.
Right.
My wrist is normal, but that 2 scars here, consequence of an injury. And that's the only recollection I have.
Right.
So it's not vanity only. For women, of course, they don't want a big scar between their breasts. If you can keep a less visual part, they're gonna favor. I struggled like hell yesterday. I had the 17-year-old girl. She had Louis Jit syndrome, but the first thing she told me, she said, "I don't want a scar in my chest." I said, "I can't do this through the scopes and all the." So I kept in between her breasts, not much breast per girl, but in between her breast, but below the level, and I work in a hole for cosmetic purpose. Did I increase the risk of the operation? No, I don't think so. Because once you transect the aorta, the whole thing moves and comes to the operative field. Made my life much more difficult. So it transfers the pain from the patient
To
to
the surgeon.
you.
Right.
Right, yeah.
I think minimally invasive is here to stay as well. Minimally invasive really means smaller skin cuts, but they have no idea what's inside. It's like an iceberg, small outside, and the bottom is will cause more damage than look at the bypass time for robotic mitral valve surgery. I wouldn't have that operation. It takes too long. 4 or 5 hours in a heart lung machine. It can't be good for your brain. It can't be good for any part of your body.
Yeah.
All right.
Dr. Kirkland, in his 70s, he used to have a blue book don't know if you guys are too young to remember John Kirkland, but he was one of the really men that transformed cardiac surgery to, he introduced statistics to cardiac surgery. In his blue book, he had duration bypass versus outcome. 1 hour, very few died. 2 hours, more died. 3 hours, 6 hours, they're all dead in those days. We reduced the slope of the curve a bit, but we have not abolished.
Right, it's not flat.
Absolutely. So it's, don't tell me that a 6-hour pump run is harmless. It's, and that's one area we have not improved very much in keep the patient alive during the operation.
You want to ask one more, and we could sit here all afternoon, but I think.
Where do you stand on tricuspid disease, and when do you treat a tricuspid valve? When you're doing an aortic procedure, coronary procedure, mitral procedure?
I don't know the answer. However, these guys gave me a difficult topic next month. I believe that if a patient has tricuspid regurgitation, you should repair the tricuspid valve. I believe in that. But they gave the reverse. They gave me to debate a guy who believes, as I do, that should be repaired, to be the devil's advocate. Don't repair. Mm-hmm. So I've been reading, like I never read so much in my life, to defend something I don't believe in. And I'm going to make an argument that's going to destroy everyone there. Let me tell you. I'm going to present to you guys evidence on pulmonary thromboendarterectomy.
Okay.
I don't know if you're familiar with this disease.
Yeah.
Those patients, 2/3 of them have severe tumoral TR. The thoracic surgeons do not repair the tricuspid valve. They do a thromboendarterectomy, 90% of the TR disappear.
So 90% success rate without touching the valve.
Yeah.
Drop
So
the
maybe
resistance.
But that's a different animal. Aren't you
No,
talking about
it's-
disease of the annulus and disease
Left
of the...
Well, it doesn't
Right.
develop the pulmonary hypertension.
Okay, so
Well,
you're
if you're
saying
talking
it's-
about mitral disease with secondary pulmonary hypertension, it's
Yeah,
sort of the cousin. It's
so
the cousin.
if the pulmonary hypertension is an arterial pulmonary hypertension, it's not harmful to the right ventricle the way if it's venous pulmonary hypertension is. I want to confuse the issue
Okay,
now.
I got it.
In other words, if you have aortic stenosis, mitral stenosis, or long-standing mitral insufficiency, the left ventricular diastolic pressure is going to go up, the pulmonary venous pressure goes up. There must be a hormonal thing, or neurological or whatever, that mediates something in the right ventricular function.
Okay.
Because the thoracic surgeon showed to us that it's not pulmonary hypertension that is the bad guy in tricuspid valve. So it must be right ventricular dysfunction that's the bad guy. And right ventricular dysfunction doesn't happen when you have arterial pulmonary hypertension. It happens when you have pulmonary venous hypertension.
Interesting.
Follow me?
I got it.
Yeah.
I got it.
Yeah.
Okay, but because you don't do thromboendarterectomy, we do heart surgery, we repair the tricuspid valve. 5 years later, half of them are leaking again. Worse than are ischemic and
MR.
function
It's
MR.
worse than,
Yeah.
it's
We don't
worse
do
than
it as
functional
well.
MR.
Right,
So we don't know the tricuspid valve.
right,
If you look embryologically, it's a nightmare of a valve,
right.
where it comes from.
Well, if you look at McCarthy's paper from the Cleveland Clinic, 15% of the patients leaving the hospital had moderate to severe TR after a tricuspid
No,
repair.
and Nadia has another paper that I'm using as a reference, published in 2010 already. And escape my, he has a graphic, up to 80% recurrence at 5 years.
Yeah.
I mean, so you talk about C tricuspid insufficiency, repair tricuspid insufficiency. Good for you, you can repair, but don't cure the lesion. They come back. So we don't know very much about tricuspid valve. We're gonna have to spend more time learning
It's very
operate.
complicated.
And then, worst of all, if you touch the valve or don't touch, you don't change the survival either.
Right.
There's no proof that
Reduce.
tricuspid insufficiency is a predictor of put-out.
Mortality, right.
Absolutely. That's why if you replace or repair, there's no difference in survival at 10 years.
If it's present, it's a predictor of
Absolutely,
mortality.
yes.
Yeah.
Yeah, but there's no proof that repairing it, you reduce the
Right.
mortality, later mortality.
Right.
You do reduce, however, hospital stay, leg edema. The patient doesn't require as much diuretic after a mitral valve surgery. There are some benefit, and that's why I do it. But am I solving the problem? A long shot. Next decade, I'll give you the answer. I decided I've done aortic, mitral, aorta, but I'm going to go to the tricuspid.
You're moving it around.
You're moving.
We're gonna, we might be here for the next decade if we don't stop this. But Peter, you have any final question for Tyrone?
No, not at the moment. Thank you for
Yeah,
for
Tyrone,
sharing
it's
your
fabulous
knowledge.
for you being with us, and we certainly look forward to
There's
your
nothing
visit.
you like to talk more about than that, and sex, but
Well, maybe we should ask about that.
You're doing-
You fix
you're
the
doing-
tricuspid valve.
every
sex
single
better?
meeting, this guy come up with a sex joke, so I said,
Is that without the sildenafil?
That's right. All right. Well, thank you so much for joining us. We appreciate it.
pleasure
Good.
for having me.